Assalamu alaikum. Welcome everyone on board. So we will be discussing a scenario. Just give me a second. Sheher Bano, would you like to volunteer? Don't be afraid, because as much as you will speak out in practice, that much you will be able to perform better in the exam. Okay. So the scenario has that we have a 34-year-old previous to cesarean section who is presented in emergency at 30 weeks with blood pressure of 200 by 120, headache. Um, Obstetrician wants you to evaluate and further management. Okay. So, Sheher Bano or Umar, would you like to speak out, please?
Assalamu alaikum, sir. I would like to evaluate the patient on management of preeclampsia.
Okay.
First of all, I would want to have a urine complete exam and and serum profile, which includes renal function tests and serum electrolytes for this patient.
Okay. RFTs and
RFTs and LFTs.
LFTs. Okay. So anything else would you like to do? With the report will come in 3 hours. So you will not do anything in 3 hours?
Sir, in the first 3 hours, I will take detailed history of the patient regarding CNS symptoms, and if she has them, I will start her on magnesium sulfate. And for control of hypertension, I will start her on labetalol, provided that her ECG is within normal
What do you mean?
limit.
What do you mean by ECG within normal?
Sir, provided that there is no evidence of a heart block.
Okay. Is it common to have heart block with the in this scenario?
No, sir, but
Why you
we
are
should rule it out before starting labetalol.
okay, fine, fair enough. Okay, what else? There is, just hint. Do you remember this ABC? Would you like to have approach like this?
Yes, sir.
Okay.
Um,
Before starting magnesium sulfate, would you like to do something? Would you like to monitor magnesium sulfate with something? Think you will find the answer. Nothing is difficult. It's very simple. You just have to concentrate.
Sir, monitor magnesium sulfate with
Yes.
uh, सर अभी तक तो उसको मतलब we haven't started a dose yet. If we had started तो फिर I would have liked to monitor her deep tendon reflexes.
Okay. Is it like when you are starting magnesium, would should you
Yes, sir.
send a should you send a sample of electrolytes as you mentioned? So you can
जी
say
sir.
the same thing that once we
Yes, sir.
once we start magnesium therapy. I don't know what's happening this. Just a second, please. You got my point, I hope.
Yes, sir.
Okay, so whenever we are using magnesium therapy, one is levels, other is deep tendon. What is the third one? ECG.
ECG.
And what is the fourth one? Urine output.
Yes, sir.
Does magnesium sulfate cause renal failure? Yes. No. Okay. Magnesium sulfate does
Yes.
not cause renal failure. Then why we monitor urine output? Why it's important to monitor urine output in magnesium therapy?
Sir, I don't know.
Think about it. Think about it. If you are thinking, oh, page number 81 of Lana XYZ book, that's something else. Okay. So, yes, Umar, you rose the hand. Please, would you like to tell why we monitor urine output with magnesium therapy?
अस्सलाम वालेकुम सर, डॉक्टर फातिमा हियर।
Yes.
एक्चुअली मुझे वो ना सिस्टम समझ नहीं आ रहा था, तो वो हैंड रेज हो रहा था और स्पीकर ऑन नहीं हो रहा था, तो
Okay.
दैट्स व्हाई आई जस्ट
Just
रेज्ड।
a humble request if you can speak in English, because maybe some
ओके
people who
सर।
yes. So sorry, it's Fatima, not Umar.
यस
It's
सर।
confusing. Anyways, so
फातिमा।
would you like to tell whether what why it is important to monitor urine output with magnesium therapy?
सर आई एम जस्ट थिंकिंग अबाउट इट, आई हैव आल्सो नो आइडिया।
But just tell me one thing. What is the
यस।
organ which monitor the electrolytes in the blood?
किडनी।
So that's why if kidney, for example, if you are loading magnesium, okay? 1 gram, 2
ओके
gram, 500 milligram per hour, 1 gram per hour. So would you like to see whether the kidneys are making urine or not? Because if they are closely regulated, okay, of course the answers are something else as well. There is intracellular shift of ions. There are so many things going into the bone and excreting through the feces. There are so many things, okay, but in this scenario, it's the one of the most important thing is monitoring the urine output. Okay, so these are the things which you should be knowing about magnesium. So Sheher Bano started with urinary. So just Sheher Bano, just think now, if you started this scenario, if you answer urinary to start with, does it look good?
No, sir.
So I hope
Uh,
you understand.
uh,
So, so that
yes.
is the answer should be that I will evaluate on the basis of airway breathing circulation. This is just a
Yes, sir.
tip of iceberg. You will just see that, and immediately you said preeclampsia. What is preeclampsia? Just tell me one thing. Does the prerequisites of there are two prerequisites which are fulfilled here. There is high blood pressure and after 20 weeks. Is there anything would you like to see before labeling it as preeclampsia?
Sir, proteinuria.
Proteinuria. Okay. So, if I'm not wrong, there are, I think, there are dipstick method to see urinary protein. If I'm not wrong, okay.
Yes,
So,
sir.
you will, because these tests which you have told will be coming in 3 hours. So if you answer like this, now I hope you understand that why it is important to practice, because
Yes, sir.
you know everything, but now suddenly when someone has asked the question, you are unable to make make sense of the question. Okay, so the answer should be, the basic theme will be the same. Okay, so these are what the, like in this scenario, what are important things. She is 30 weeks, so these things will be related to the obstetrician. Okay, so you will discuss with the obstetrician what's their plan. Okay, and in the meantime you will try to optimize the patient. If at any time, and you did not, you mentioned about this CNS. Okay, so categorically you have to mention about fits. Okay, because the barrier between preeclampsia and eclampsia will be the fits. And this, in this scenario, if it is really like preeclampsia, and anytime patient can develop fits. So you have to, so you have three aims in this patient. Number one, control of BP. Okay. Number two, prevention oblique control of fits. Number three, delivery of the baby. Okay. Delivery of the baby is not related to you, but you will discuss with the obstetrician, and it will always be a risk versus benefit. Of course, you will try to proceed the pregnancy, But at any point of time, if you have to decide, because 30 weeker can survive. So what you will tell that we will discuss with obstetrician, we will arrange with the neonatologist, we will discuss with the family, and we will have to proceed with the either initiation of this labor, or in this scenario, because the patient is previous to, so elective cesarean, sorry, it will patient will proceed for cesarean section. Okay. So what else you can do, Teharbano? Now, neonatologist I told, family discussion I told, and magnesium we discussed, control of blood pressure. One thing, would you like to give some medication in this patient with reference to 30 weeks?
Yes, sir. I would like to provide steroid cover for fetal lung maturation.
Yes. Okay. So steroids. So now what you have to do, because this is a very common scenario in among the obstetric scenarios. Okay. So you can chalk it down, and 5-6 points you should be written in the form of buzzwords: magnesium therapy, urine output, deep tendon reflex, ECG, and levels. Okay. Control of blood pressure, control of or prevention of fits, delivery of the baby, discussion with the family, post-op ICU, NICU, and that's it. Okay. So now there will be some more questions for you to discuss. GA versus spinal versus epidural. So how can you compare these three things in this patient? Yes, please. And another important thing, would you like to have some more investigation immediately? Like you should say about CBC, because now you should be thinking about the complications of preeclampsia or eclampsia. Okay. So there may be some abdominal
Population
problem,
profile.
coagulation profile, and CBC, hemoglobin. Okay. Platelets. What is HELP syndrome? Okay. So you should be
Hemolysis. Yes, sir.
elevated liver enzyme and low platelets. So you should be
No
thinking
platelet.
about, like, remember one thing. Now you just have to identify with what are the problems which can be there in this patient. So just think about it. Let's recall again. What are the problems in this patient? One is with reference to fits, ABC, okay, magnesium therapy, delivery of the baby, and premature baby. Okay, and these patients can can bleed because of involvement of this thing. Okay, and the nightmare will be if this is combined with, because there is previous to cesarean section. So does it is it a disposing factor for placental abnormal placental things like placenta previa or accreta or percreta or whatever? Okay. So you just have to, they will not be asking you each and everything. They cannot ask in 5 minutes. Okay. So you just have to arrange your answer in a way that you have this patient, and these are the things which you have to manage. Okay. So another now choice will be GA versus spinal versus epidural. Okay. So what will be the advantages of GA? Quickly, quickly. Airway will be controlled. Can someone speak out? It will be your practice. Airway control.
That
What
we
else?
have a better airway control,
Okay.
or
Hemodynamic.
as the patient has previous hemodynamically stable previously two scars, so there may be the abruption or accreta.
Okay. So hemodynamic control is better. But what will be the
Yes, sir.
problems? The problems will be the most
It's a
important will
difficult
be
airway.
intubation response. Okay. And difficult airway like in any
Difficult.
pregnant patient. And another thing with magnesium therapy, increase
Prolonged effect
response.
of muscle relaxation.
Okay, so now again, make these a buzzwords. Immediately, you have to tell in few seconds. There is better control of airway because patient can have fit. hemodynamics, and another advantage will be that maybe patient have impending, you can use this word, impending coagulation problems. Okay, because of involvement of liver or these platelets. Okay, so airway control, hemodynamics, impending. So these are the things. What are the advantages of spinal? You will avoid
Avoidance
these
of a pressure response on
pressure
laryngoscopy.
response. Yes. Okay, and the blood pressure will be controlled actually, but there will be exaggerated fall in BP. Okay, because in that time you should be just recalling that the basic pathology. What is the basic pathology of hypertension in PIH? This preeclampsia. Can you tell, Fatima or Sheher Banu, or anyone wants to speak out? What is why the blood pressure is increased in this scenario?
Um, Sir, the blood pressure is increased due to abnormal placentation, which causes an increase in endothelium in the mother's blood,
Increase
which
in what?
causes hypertension.
There is
So,
imbalance between
endothelium. Yes, sir.
imbalance between vasodilators versus vasoconstrictors. So thromboxane A2 versus prostacyclin. So there is increased thromboxane A2. Prostacyclin is the vasodilator. If I'm not wrong, just correct me. It slipped out of my mind. Just correct me. Am I right? Thromboxane is the vasoconstrictor and prostacyclin is the vasodilator. There are some other molecular pathologies as well you should know, because they can ask you. They will not fail you, but you should know the exact. There is some problem in the calcium or something like that, which I don't remember at the moment, but you should be knowing, because they can ask you these questions in between. Okay, they can ask you in before the start of the scenario or in between, but remember one thing, you will fail or pass by the management, not by these one small question which is just a teaser. Okay, they will not fail you. If you tell about this thing, this is a passing point. If they are asking further more points, this is just for giving you extra marks. So they will not fail you if you are not able to tell too much detail, because ultimately there is the basic pathology is this thing, abnormal implantation of the placenta leading to imbalance between vasoconstrictor and vasodilator. But I can recall that there are some other points as well. Okay, so we discuss about spinal. The advantage, the advantage is that you will avoid the stress response. Okay, what about epidural? Any advantage of epidural? How you can say, how can you compare spinal versus epidural?
More hemodynamic stable.
Okay, more like more like controlled as compared to spinal.
Control the drop in the
And
spinal
post-op analgesia.
and the post-operative analysis, and we can pop up those the intra-op if we need it.
Yes. So, but what is the problem? The problem between epidural and spinal will be the size of the needle, because here you are using 18 or 16 versus 25 or 27. Okay. So if you have impending coagulation problem, so epidural will be not good. Okay. So they, like, actually there is nothing safe. Neither GA is safe, nor spinal is safe, nor epidural is safe. You just have to sell your product. If you want to defend spinal, you should know what is the advantage of spinal. If you want to defend epidural, you should know how to defend epidural. And by the way, you can say combine epidural with GA. Epidural you can use only for analgesia. Okay, and still you can give GA. So this is another way you can tell. But whenever you are placing epidural or giving spinal, you should tell that we will outweigh risk versus benefit, the advantages of giving central neuraxial block versus the problems which you can have. And it's always a tricky decision. Okay, so you should be knowing about it. Okay.
So
So
there's
now,
another thing that we can
yes, yes,
there
Unera.
is another thing that we can add, like the spinal. Okay, it's going to help us with the reflex of the laryngoscopy, but it cannot save from the cytokinin stress response. No, that is
Cytokine.
going to happen. The increase in the ACTH and the cortisols.
Yes. But that is not an acute effect.
We cannot add that. No.
You can tell if they ask, maybe in your exam, Zunera, maybe they may be interested in listening, but generally this is not the immediate thing. Okay, the inflammatory response you are talking about is decreased, why it is relatively less in spinal, because you are blocking the sympathetic pathway for that pain. But overall the body in this case, already there is a stress, already all the hormonal mechanisms are in opposite direction. Of course that will not be
No,
reversed
sir.
by.
I'm saying in spinal cannot avoid that.
Yes,
Actually,
that's
GA
what
can
that's
avoid
what
it.
I'm saying, that
Yeah,
spinal will not
yeah.
avoid those that part. So you are right. You are absolutely right. Okay. So that's how. So now, how will you blunt the, if you want to give GA, how to blunt the stress response in this patient? Like, this patient is already receiving magnesium. This patient is already receiving some labetalol. Anything else would you like to do? This patient is at risk of aspiration. Okay.
fentanyl, lidocaine.
Okay. So you will be using opioids. You will be using lidocaine, IV, and or spray. What else? Short acting beta blockers. You can top up. Okay. And short laryngoscopy time. You can make a ramp position. You can do pre-oxygenation. You can use rapid sequence, or better to have modified rapid sequence induction. You can have arterial line pre-induction. Okay. You should, or you can have cardiac output monitor. Okay. If the patient is not hemodynamically stable, maybe you should have either 14 gauge or 16 gauge cannulas. Or if there is no pure indication of CVP, but if you have cardiac output monitoring, so you can use, say, these things, use of POCUS. These are few points which can increase, like POCUS in this scenario. What will be the help of POCUS? This is some additional points. Stomach residual volume. Okay. And the fluid status. And because this patient already can have pulmonary edema because of leaky capillaries, so you can say that few things. You can, if you have the what is the scientific reason for wide bore peripheral IV lines? Yes, Bilal,
So,
you
which cardiac output monitoring would you prefer?
cardiac output, the simple, the like
Litco and the Pico?
yes, Pico, pulse contour, the
Okay.
Vigilio. Okay. Or even Massimo. These are actually company names. So can I, as Bilal asked this question, is there just a second. Okay, so is there what is the reason of wide bore cannulas? Can someone tell?
It's because of the pressure, the Hagen-Poiseuille equation. Like we have
Mhm.
the bigger radius and the flow will be
Increase.
proportional.
Uh,
Yeah,
Bilal,
4 times
Bilal,
the radius.
Bilal, would you like to tell? Would you like to tell what's your point? What's in your mind? Maybe you need to give vasopressors, and why we need it. Yes, Bilal,
No,
would you?
I'm saying that why we need wide bore cannulas. I know that flow through the cannulas is being explained by Hagen-Poiseuille, and that tells you the flow dynamics. But why? Okay, So what is the blood supply of non-gravid uterus? Like how many mils per minute? And what is the blood supply of gravid uterus?
Yes, this is yes,
Sorry, sir,
Zunaira.
what you are asking?
Work the blood
I'm
supply
saying
of
that
a normal
everybody,
uterine
listen,
blood flow.
the people who do OB is a high risk patient, right? There is a misconception that even in somebody who is at term, like any OB patient coming for some anesthesia help, they are not normal patient. Always we say this patient is normal, no issues. Every pregnant patient at term has one foot on the earth and other foot on the heaven. Anything can happen anytime. They become unstable anytime, despite of having any other associated conditions like PIH, preeclampsia, eclampsia, GTM, whatever, are some baseline cardiac issues. So non-pregnant uterus. So first of all, uterus is being supplied. Major portion is coming through two uterine arteries on either side, right and left. So non-gravid uterus has a blood supply of 50 ml per minute, but full-term uterus has a blood supply of 750 ml per minute. So that's why people advocate to put the wide bore cannulas at least 16 or 18. Though even if we are able to put in two PIVs of 18 gauge on 16 gauge on each side, we cannot catch up in terms of massive hemorrhage if, let's say, patient starts bleeding. Because if you look at the flow capabilities of every cannula, I guess 14 gauge cannula is able to infuse volume at a rate of 300 and something, but gravid uterus has a blood supply of 750 ml per minute. So this is always, I am a very strong believer of good running IVs and secured airways if indicated in any anesthesia case, if we are not talking about regional. So this is a scientific reason that gravid uterus has a blood supply of 750 ml per minute being channelized by two uterine arteries. So that's why always we have to have a wide bore IVs. Second thing is, it doesn't matter that you do these cases under regional or GA, but of course, regional is the first priority for any OB case until unless patient refuse or we have some technical issues in getting done that neuroaxial block, or patient starts bleeding or starts deteriorating and we have to convert that partial or fully working subarachnoid blockade or any neuroaxial blockade into general anesthesia. But always we have to have a backup plan for all these patients. And this is the OB anesthesia is just like any other high risk service like cardiothoracic anesthesia, transplant anesthesia, because patient stability is being changed at any spot. So that's why two IV lines are always necessary. Some people feel very comfortable with even one IV, but never start your case without two IVs.
Thank you, Bilal. So this was one point. So because we have to finish in 5 to 10 minutes, I have limited time. It's getting late. So thanks, Bilal, for your input. And because we have almost covered a number of points about so the use of POCUS will help. POCUS can help. Okay, of course. if you are answering this question in the Viva, be a little careful, especially in in Pakistan when you are answering. If you start your answer with focus, examiner will catch you that you are just trying to be very.
But simply, if you want to talk about POCUS, POCUS can tell you the residual volume in the stomach. So if you are trying to use POCUS to evaluate the gastric volume, patient should be in a right lateral position. So we focus the patient in two positions, spine and right lateral position. Okay, and any volume more than 150 mLs, we consider them full full stomach. So based on your expertise on POCUS, we are able to identify solid food, semi-solid food, and mixture of semi-solid and solid food. But again, if somebody is trying to evaluate the stomach condition in terms of fullness in pregnant patient, it's usually challenging because whole anatomy is being pushed to some abnormal position due to gravid uterus. And if you want to evaluate cardiac function on the POCUS is all about eyeballing. Eyeballing means that you are watching real time on ultrasound scan at RA, RV, LA, LV, and people use few views, short axis view and long axis view if you have a parasternal approach, or subcostal view or apical view. So POCUS is all about eyeballing. Majorly people are able to look at four chambers, how they are filling, how they are moving. If in terms of movement we see that if there are any regional wall motion abnormalities, how the contractility force, how is the pattern of contraction and IVC volume. And in the lung ultrasound we can identify pneumothorax, we can identify the lung sliding, we can identify pleural effusion. So these are the main thing which anesthesiologists should know. But if you are not expert about it, I think it's not a good idea to talk about it. And I do 50% OB here in the New York. We never use the cardiac output monitor here, Lidco, Pico, or Vigilio even. Because OB is anesthesia, honestly, anesthesia is same across the globe. There are few changes in standard of care or approach of the people, but usually it's the same.
Yes, thank you, Bilal. Actually, these are the stock answers. Don't tell in the start, but if they are asking more and more and more, so maybe keep this cardiac output monitoring or focus at the last. If maybe they just wanted some extra point to start with this pre-oxygenation, arterial line, uh, modified rapid sequence reduction, ramp position. These are the things which you can safely say. Okay, acid profile access, and then of course this patient will be needing judicious fluid management. You will definitely like among the monitoring, you can say that in addition to standard 1 and standard 2 monitoring, we would like to have arterial blood pressure monitoring or neuromuscular monitoring because of use of magnesium, and you have to continue magnesium in the perioperative period. When we stop magnesium sulfate.
Isn't it
Yes,
after 24 hours
I'm
when there
sorry.
has been no seizure? Isn't it after 24 hours when there has not been not any more seizures?
I think 24
Sir,
hours
there is
seizure.
plenty.
Sorry,
Seizure-free time, like 24 hours with seizure-free time.
I don't remember exactly. Just reconfirm. I think it is post-operatively you have to, sorry, postpartum you have to continue, and I think this is one of this point is that 24 hours after last seizure. Okay, so you just I have this a little bit of confusion that uh, if there is no fit, would you like to stop after delivery immediately, or you still have to wait for 24 hours? This is just reconfirm about
We
it.
have to wait, yes. We have to wait for 24 hours.
Yes, I think this
Yes,
is
Like
sir.
there
this.
should be a seizure-free period
The,
with
Yeah.
the
24-hour
reason is
time.
that most of the seizures occur in the post-operative period
Okay.
in the
I'm sorry.
eclampsia patients.
I'm sorry. Say it again,
Yes,
please.
sir.
Sir, 80% of the seizures usually occur in the postpartum period. So it's better to continue magnesium sulfate infusion after the
Listen,
delivery of the baby.
Dr. Hiba, I will just correct one thing, small thing. Even if you are sure about the number, you don't need to use these very big words in Viva, because if you say 80% in post-operative period, I'm a little doubtful about it. Maybe it is correct, but maybe it's not written in their key, and you can surprise them. Okay, so like you don't need to tell these numbers without unless they ask you. You got my point? Just like Bilal mentioned that you don't need to mention cardiac output unless you are very sure that you have passed. Because if you start your answer with cardiac output or POCUS, maybe they can catch you. I was just telling you that this is something extra which this thing should be in your mind. Similarly, I'm not sure about the data that the preeclampsia or eclampsia, the post, yes, the word is that it can occur after, but I'm not sure about. Maybe you are correct. Yes, Bilal?
Yes,
So
sir.
in this patient, the main other concern is that platelet number is very important and their trend is very important. Let's say someone comes on the triage on OB floor and the platelet is 124, and still you are thinking about to do spinal, right? But they send another sample after 2 hours and platelet come out to be 70. So it means that it's falling, the rate of falling is very significant, so you have to be careful. Second thing, people do combined spinal epidurals also, even epidurals on them for labor analgesia. So always there is another concern that maybe we are going to put the epidural catheter in right now and that patient has a platelet number of 100, right? So we are okay, but again it's tricky to take the catheter out, but maybe because maybe due to this severe disease post-operatively that patient goes into DIC or have significant derange of coagulation, then to take catheter out is another problem. So these things all depend on the local policy and departmental you know practicing guidelines, so stick to those. And in general, in the Viva exam, when any examiner asks any questions, don't get depressed. Try to understand the question. Take your time. Let your brain to collect data for 30 seconds and then formalize your statement and then articulate. Don't say anything abruptly. And if you do not know anything hi fi, try not to say anything. For example, if your patient, they create a scenario that your patient develops cardiac arrest right after the delivery of baby, and you pick up the situation that this patient has develop AFE, amniotic fluid embolism, and one of the part of care for AFE is ECMO. But if you don't know anything about ECMO, try not to say. But if they really want to listen the word out of your mouth, you can say ECMO. But if you do not know anything in detail about that, it's always better to say them, I don't know much about it. Rather, you start guessing some statements and then they will be very happy to push you in a gray zone and mark you that you need to re-come again for the exam. So it is very you know wise approach that you know your limitations in terms of your knowledge and skill, and play based on your knowledge and skills, and you should be more presentable, cool, calm, try to get your nerves, try to get your back. So in Viva exams, these things are more important, and stick to the basics. Always start about, no doubt we need to tell our specific concerns to every patient, but general concerns are also important, like NPO, any medication allergies, any previous anesthesia history, any bad head history, any bad anesthesia history in the family, how patient behavior was in this patient when she got last time to cesarean section, how she tolerated anesthetics. So these general concerns always have a room to build up your confidence and to grab the examiner concentration, their focus, and to make them realize that, to assure them that you are a safe anesthesiologist and you are good to go to pass the exam.
Okay, thank you very much, Bilal. So I just highlighted some points about amniotic fluid embolism as Bilal mentioned. So you can tell about ECMO and important things, but important thing will be airway breathing circulation, call for help, ACLS
No,
protocol.
I'm not saying tell them ECMO in that. I'm just saying that
No,
don't
no, no. You're
start your
yes,
management
yes,
from
yes,
high-fi thing, right?
yes, yes.
For example, AFE, it's all about assessment and resuscitation. So if someone is trying to do resuscitation, someone is trying to bring the heart back, right? Someone is more focused on ACLS guidelines, they're gonna pass. But it's not like that if you're not gonna tell them that ECMO or some we are not able to get IV lines, we have to get intraosseous lines. These are advanced standard of care, and it depends. Few things are mentioned in the books, but I guess in a viva exam, if someone is asking out of the box or out of expected things which are not happening at ground levels, it's not fair, and people do not ask usually. We have been listening that someone went to the exam and the examiner was so cranky, and he or she was asking, you didn't measure the fundal height. Being an anesthesiologist, this is not our job to learn the fundal height. To learn how to measure a fundal height is not gonna change our management, but still people do nonsense sort of attitude being an examiner in the exam, but it's not fair. So probably basic things, and people are able to present them, and they are well focused and they understand the situation, and if they are at that level of their journey that they are able to pick up a complication and they are ready to react to it, it's good for them, and I guess they should be passed.
Okay, thank you. So, so for amniotic fluid embolism, airway breathing circulation, assessment and evaluation and management will go side by side. ACLS protocol, peri-arrest cesarean section, left uterine tilt, and this is a slightly higher chest compression. These are the things which they can ask you. Other things, what else is left? Few words about these uterine tonics. Okay, so either it is oxytocin. So what will be the Wajiha? You had raised the hand. You'd like to say something, please? I couldn't give you a chance. Wajiha, did you raise the hand? What you wanted to say?
Sir, वो that comment about magnesium sulfate after delivery 24 hours that has
Okay.
gone fast.
O- Okay, okay. So, some words about these uterine tonics or PGF2 alpha. So, you should be knowing their side effects, oxytocin overload, tachycardia, arrhythmias, hypertension, and also like with PGF2 alpha, there is bronchoconstriction. And so, these are the things they can ask you. What else? Massive blood massive hemorrhage, what you need to tell the same large bore IV cannulas, okay, and activation of massive transfusion protocol MTP, massive transfusion protocol in which there is a set amount of uncross match PRBCs, FFPs, and platelets they will send. This is a hospital based practice, okay. So MTP and rapid infuser system. There is level 1 infuser, rapid infuser. Okay, warming fluid warmers, and what else? Uh, there are something which are related to surgeons, but you should be knowing about it. Packing. Okay, then B-Lynch. I'm not sure about the spellings. B-Lynch sutures, cesarean hysterectomy. Okay. And then there is something which I'm not sure exactly about the spelling. Bakery balloon. I think like this Bakery balloon. It's a tamponade. It is placed per vaginally, and it is inflated, and it is like tamponade effect. Okay. And of course there are some other things which are related to massive bleeding, or so maybe the involvement of general surgeon, urologist, in case there is a like placenta accreta or increta percreta. Okay. And then interventional radiologist for balloon tamponade of embolization of internal iliacs. Okay. So internal iliac vessels. So these are the things which they can ask you. You should have some idea about what is the management for these things. So I will just recap. We started with a scenario in which there was hypertension and there was headache. So you should be telling that I will evaluate the patient on the basis of history, examination, and investigations. And because this is a emergency situation, patient can suddenly fit, patient can lose the airway, patient can aspirate. So my approach will be airway, breathing, circulation. I will immediately discuss with the surgeon what's their plan. Maybe we can discuss with the family. We can arrange an ICU. We can arrange PICU, sorry, ICU for the patient, and we will control the blood pressure with magnesium sulfate or labetalol. Maybe we can proceed with. So this should be your answer. So if you will not be able to gather all the aspects, you will unfortunately, because there are so many things you can speak out, but you have to gather what you have to, how you need to arrange the answer. So fits, bleeding, magnesium sulfate, and like other maneuvers to control the things. How to monitor magnesium, how to monitor the muscle relaxant effect, which fluid to be given, like a combination of like colloids, especially if you have albumin, because there is it will not lead to volume overload. It will remain in the circulation, because in this PIH, this preeclampsia, there is severe vasoconstriction, and actually intravascular volume is reduced. So actually you need to give fluid, and because of leaky capillaries, and so these patients can go in pulmonary edema. So if you give albumin, that will help you. And you have to calculate the allowable blood loss, and you have to assess the surgical field, you have to assess the drains, you have to assess the gauzes, the sponges, and then you have to decide how much and when you will be giving the blood. So these are the things which they can ask you. So I think any question or anything anyone wants to add? Bilal, you want to add something, or any questions, please, before we finish?
So in this, especially people with preeclampsia or eclampsia, they are very sensitive to vasopressors also, like phenylephrine or ephedrine. So probably try to just use a little touch. Like if you are giving regularly like a 3 milligram ephedrine bolus or 100 mics of phenylephrine push, try to give them half because they are very sensitized. So they have rebound hypertension. Like if you give GA to this patient based on any factor, based on any justification, and they crash or they're hypotensive, then maybe they are very, very sensitive to the pressure effect. If you compare this OB patient to other OB patient who is not having PIH or preeclampsia or eclampsia, so they have more sensitivity to the effects of pressors. And in OB in general, usually try. I think it's worth mentioning to tell examiner that I will explain everything to the patient and to the partner as well, because it is very important. And what else? Like massive transfusion, they may ask you the definition of massive transfusion. When you say massive transfusion, so massive transfusion is that anything like if someone is bleed at more than 120 mils per minute, or loses half cell volume within 4 hours, or full cell volume, which is 5 liter. When I say full cell volume, it means 5 liter of blood within 24 hours. So this is the exact definition of massive transfusion. And massive transfusion, if you are mentioning the level 1 transfuser, which are electronic, they have their own circuit, and level 1 transfuser is capable of infusing blood at 500 ml per minute, then again the major consideration is recline or cordless lines, which are really wide bore, 7.5 French or 8.5 French. I do not know people are using here in Pakistan, but again, they may initiate discussion on that, because if you say level 1 transfuser, one of the brand name is Belmont. So you say MTP activated and I will use Belmont. So if you start your Belmont on gauge 16 or 18 gauge PIV, it's gonna rupture that cannula. Imagine that if some device is able to push volume at a rate of 500 ml per minute, it has to have a widest bore entry point into closed circulatory system of that patient. You know what I mean? So if you talk about massive transfusion, and if you say about level 1 transfusion, then the type of access is very important, which is usually recline or peripheral sheath or cordless line. Cordless line usually they put in the neck, internal jugular, and the recline is peripheral sheath is just like, it's even wider than 14 gauge cannula, and people use the cell linger technique to put it in, and they suture it so that it doesn't come off with a lot of pressure being generated by level 1 transfuser. And of course, when we talk about MTP, everyone should be aware of that. It's all components of blood, like platelet, FFP, cryo. You give everything. And then in massive transfusion management, calcium is very important, because as a chelating agent, all the preservative which are being transfused with the blood, so the calcium level falls. And of course, when patient lose volume, at certain point we are unable to catch the resuscitation in terms of volume, and patient is losing more volume, and we are not able to infuse equal amount of volume. So if they are acidotic, bicarb has some place in resuscitation. And in resuscitation, if patient is really bad, so probably you give everything whatever you have it. And one thing I want to mention, that here in the US, uh, I'm not talking about PIH patient. Normal OB patient, the first drug which we give is ondansetron, because there are few studies which say that if you give first drug ondansetron, doesn't matter that you are doing regional or GA. Usually we do most of the cases under regional. So ondansetron has some correlation that it reduces the pressure requirement. So we give very first drug ondansetron and do spinal, and right after spinal we start a low dose phenylephrine infusion to that patient. And there are studies in the literature, you can Google it or you can search it on the PubMed, that if you use ondansetron as a very first drug, the pressure requirement, which is usually required to counteract the CVS changes, secondarily to sympathectomy being done by spinal block, it's much lower than those people who don't get ondansetron as a first drug. So I think it's a worth mentioning. I don't know you guys are aware of it, but we do it here all the time and it works very well. And
Thank,
in
thank you,
and
Bilal.
in especially for amniotic fluid embolism, there is a debatable point. AOK, people give these three drugs: atropine, ondansetron, and ketorolac. So SOAP, the Society of OB Anesthesiology here in America, they advocate the use of AOK in AFE. It's helpful, but some literature data say it's not. But when we have such a drastic condition like AFE, so in general, if you want me to define AFE, what happens in AFE? heart is blocked due to right heart arrest due to pulmonary embolism, and then ultimately that patient goes into left heart arrest also, because everything is being cluttered in the system, and at the same point patient is bleeding due to cytokine induced all these changes. So society says that AOK is helpful in certain cases during resuscitation. So we give AOK as a single shot, atropine, progesterone, ketorolac, and sometimes it helps. I don't know how it helps. I exactly don't remember, but it is mentioned in the literature. But these are few hi-fi things. But maybe if you say to someone who is not aware of it, they may get mad on you. People get offended sometime if some trainee knows better than examiner, but few people accept it, and they get interested that they may get impressed that. So you know what I mean. But in general, as we are talking, so it's worth mentioning. A-okay.
Thank you, Bilal. This is something new for me. That's why, it's always better to learn every day. Thank you. Thanks a lot for your input. So in the meantime, I just wrote down few of the words about multimodal analgesia. So paracetamol can be given. NSAIDs, there are some doubts with reference to renal function, but they are not absolutely contraindicated. You can say according to the case to case, you can give opioids. Presidex, central nerve cell block, again plus minus. Step block is a good option. Local infiltration is a good option. And then you have to look for the complication of massive blood transfusion, because I just open up the scenario. I just wanted to cover more than only written discussion in the scenario. So we all the changes of physiological, pharmacological, and anatomical changes of pregnancy. Then you should be considering difficult airway, easy desaturation, high cardiac output, risk of DVT and pulmonary embolism, the sensitivity to local anesthetics, low requirement of MAC. These are the things which are common things about pregnancy. Okay. And then we discuss about this hypertension. You should be knowing the terminologies. What is PIH? What is preeclampsia? What is eclampsia? What is HELP syndrome? How to diagnose preeclampsia? Magnesium therapy? How to initiate? How to monitor? What are correlation with the anesthesia? These are the maximum question they can ask you. And when they started the question, they can ask, how will you choose GA versus spinal versus epidural? So if you start with this open
And
thing,
in this sorry, it's another point in this PIH or preeclampsia patient. There is another point which patient tells you, and it indicates severity of disease. Patient may say you, I have a right shoulder pain, I have a pain in my right arm. So probably it's, so people ignore it. Their blood pressure is okay. That's not terribly bad. Maybe the systolic is in 150s or in 160s, but patients say I have a continuous pain in my right shoulder. So probably their liver is so engorged and capsule is being stretched, and they are having referred pain, and these patients sometimes have a spontaneous rupture. Of course, in this situation we cannot do anything despite of resuscitating that patient. But again, few alarming things we sometimes ignore. We sometimes say patient is malingering, but sometimes patient tells you a lot. And second thing, what is the idea of you guys that how these natural catecholamine are helping the uterus, like these adrenaline, noradrenaline, in terms of uterine tone? You know what I mean? What I'm asking?
Bilal, again, please repeat.
Like, what is the effect of catecholamine on uterine muscle tone?
They should decrease the tone if you are talking about beta beta 2 mediated.
So how it is important? Why this point is important for us?
It will bleed. Patient will bleed or more.
No, in terms of fetal instability.
Fetal instability. I don't know. It should be.
Like
It
if
should.
let's say we are going to one of the L&D room and nurse say that this patient is requesting for labor epidural, right? So if we do labor epidural, right? So it will be like a sympathectomy. So what can happen to uterus?
So decreased blood supply, fetal compromise,
No.
fetal distress.
Yes, another point. So if we do sympathectomy, let's say I went to a
It's like a
laboring
block,
lady and
sympathetic block.
combined spinal epidural. Like I did epidural, then I with it's 26 gauge, I did spinal and I just injected 0.1 to 5% of bupivacaine plain just to calm her down. And immediately nurse says you, oh, baby is dipping. So what we did sympathectomy on patient and catecholamines were maintaining the uterine tone. Now their effect is gone and uterus all of a sudden went into the continuous contraction. That's why baby developed into fetal bradycardia, instability, or baby is having dips. So immediate measure is to put her on her back, right hip up, give some volume and give some pressure. So there are few things which we are not aware, but we can prevent stat C sections. So always, if you are doing labor analgesia, be gentle in terms of your loading epidurals or doing combined spinal epidurals, because in a normal laboring patient, these catecholamines are maintaining the uterine tone. They are doing uterine relaxation. And once you do it, that relaxation is gone. And sometimes uterine muscle go mad and they go in sustained contraction. Due to that, baby has dipping and patient are being pushed for stat section. But I think if anesthesiologists know this point, you guys can prevent a lot of stat sections.
Okay. So
Does
thank
it
you.
make sense or not?
Yes. Okay. So I will just finish the discussion here. Thanks a lot, Bilal, for your input. There are some of the discussions which I did before, and you can see in the playlist of this gynae I will share it again. And any question about it, please, you are free to ask anytime. Okay. So thank you very much, all of you. Thank you. Special thanks to Bilal. And if you have any questions, please, you can share in the group or you can ask us. Okay. So I will stop here.
And one more question. Dr. Zishan, you do labor epidurals or no?
Not much. Usually,
In your center, there is no labor
no, no, there
epidural.
is labor epidural,
Any of
but
the resident who is very
yes,
good in labor epidurals?
yes,
Hello?
Zunera, or anyone want
No,
to speak?
sir, I'm not.
Yes.
No,
So what you want to tell,
any of
Bilal?
the resident who is trained in a center where people do a lot of labor epi? No.
Okay, you can tell what you are.
We are. We are.
Yes, Dr.
What?
Khalid.
Yeah. We do.
Your voice is not clear. Bilal, you can speak out what you want to tell, please.
No, actually, when I came here, it was quite interesting for me here. People do DPE. They call it dura puncture epidural. What they do, they go to epidural space, okay? And doesn't matter they're gonna do spinal dose or no, they always puncture dura with 26 gauge needle to make sure CSF is coming back. I started asking them that why you are doing this technique. They say that if, why we are doing DPE, because if you get CSF, it tells you, and this is another confirmation that you are in epidural space. And second thing they say, when we puncture dura, we are sure that we are in a midline, so there is less chance. They assume that it's not gonna be partial or unilateral. And third thing is say that we puncture the dura with 26 gauge needle, so some very little amount drug goes continuously into intrathecal space also, and it has a more better blockade. And here they have done a lot of studies. They are not believing in continuous bolus. They put patient on intermittent bolus, 9 mLs of epidural bolus every hour, and they give them a control also. Patient can inject some bolus every 10 minutes. So they say the intermittent bolus has a better analgesic control. So DPE was quite interesting practice for me here. They call it dura puncture epidural.
Interesting. Dural.
Here everything is interesting. When you come here, you will see that what we are doing and what they are doing, but they are not doing anything without any justification or research or some data. That is 100% sure.
Okay. So thank you, Bilal, for your input. Uh, so I will stop here. So
Yeah.
thanks a lot for your time, Bilal. And inshallah,
Sure.
see you again. Bye bye.